People's healthcare needs vary enormously and change over time depending on age and state of health. On the other hand, the cost of healthcare has consistently been rising above the inflation rate over the last decade and a half. Although only about 17% of the South African population, millions of people have had to make that often difficult decision of being on a medical aid to cover their healthcare needs, of course. Now, there are many medical aid schemes in South Africa offering a myriad of healthcare options ranging from hospital plans, comprehensive cover, and so on. Now, the question is, do we all know the ins and outs of medical aids? How are they regulated? How do they allocate benefits? And why is it that some people run out of funds halfway through the year? And perhaps more importantly, what can one do to avoid depleting medical savings accounts too early in the year? Well, stay tuned because these are some of the questions we tackle in today's show. We focus on medical aids. We've assembled a panel of experts to help us better understand how medical aids work and the responsible use of medical aids. And joining me in this discussion is the Principal Officer of MedShield, the General Manager of Stakeholder Relations from the Council for Medical Schemes, and an Executive Director from MedScheme. So sit back, relax, and learn from this exciting show ahead. Call us with your questions or views on Johannesburg 714-6841, 6842, or 6843. You can also tweet us, by the way, at SABC Health Talk, or simply just interact with us on our Facebook page, SABC Health Talk. I'm Dr. Sello Mutaung, and this is Health Talk.
I've had medical aid for the longest of time through various medical aid schemes. I've never used one simply because I'm not a sickly person.
They promise too many things, but end of the day, they are not going to give the money for blood tests and some other services, and I'm supposed to pay from my pocket, so I don't feel any use, any point to have a medical aid.
Because the cost, I think it was around about 3,000 rand. And at the time I only had one child, so I was going to cover my child and myself, so I decided to not to proceed with them as it was too costly for me at the time.
I don't have medical aid at the moment. Main reason I'm unemployed, can't afford it as yet.
The advantage is that in case of sickness, in case of maybe accidents and things like that, because normally private hospitals, they need cash, and at that particular time you'll find when you don't have cash, and then you need urgent medical attention and all. So I think that's one of the reasons why it's beneficial to have a medical aid.
Bengesibhedlele bafuna access fee ye-500 rand. And if maybe bengasinayo ngaleso sikhathi bekuzenzakalani, then I had to swipe money leyo 500 so that I can go through my operation. And it was a little bit ridiculous. While your service provider, they know you're paying monthly, but then why do they want that excess fee? It doesn't make sense, you know?
Currently no problems at all. Quite happy. It's reloaded in January and there's funds available.
I'm happy with my current medical aid and the rates. They are reasonable enough. So I don't have any disputes or whatsoever. I'm fine with them.
So there are different views, that people have on medical aids, and perhaps you may want to share yours by either calling us or sending us a tweet. But to learn more about what we're talking about today is two very special guests here in our Johannesburg studio. We have Dr. Elsabi Conradi, who is the General Manager, Stakeholder Relations at the Council for Medical Scheme. Welcome to Health Talk, Dr. Elsabi.
Thank you, and good morning to the viewers.
All right. And of course, next to her is no stranger to this show, Dr. Stan Molabi, Principal Officer, MedShield Medical Scheme. Welcome to Health Talk once more.
Good morning, Dr. Mutaung, and good morning to the viewers.
All right. And we move across to our Cape Town studio. Welcome another special guest, Dr. Lungi Nyati, who is Executive Director of MedScheme. Welcome to Health Talk, Dr. Nyati.
Thank you very much. Good morning, Sello.
All right. Okay, perhaps let's start with you, Dr. Conradi. Now, there's lots of confusion out there. Many people don't understand the difference between a medical aid, a medical scheme. Sorry, perhaps that's one thing, but hospital cashback plans, insurance products, and so on. From the councils, perhaps you'll tell us about, what the role of the council is in all of this. But what is a medical aid?
All right. Medical aid actually does not exist.
Right.
What happened in the 1967 Medical Schemes Act, provision was made for employees of the mines and ESCOR, and medical benefits were offered to them where they obtained the benefits at hospitals owned by the employer.
Right.
Those members then wanted more freedom. They wanted to explore and have other benefits as well. And then medical aid was included.
Yeah.
However, since the inception, we spoke about medical schemes, and in the current act we also refer to medical schemes. So your medical scheme offer your benefits. It is not actually a medical aid. So it's just the correction of the terminology.
All right.
But a medical scheme offer open enrollment, which means that no one may be turned away from a medical scheme. And in an open medical scheme, the member has a choice which open medical scheme they want to join. The contributions across the particular benefit option are the same, so there's no discrimination whatsoever. And a medical scheme also may not turn away any application based on arbitrary grounds.
Okay.
The only difference in the contribution on a particular membership option will be the difference in the number of dependents, and then also maybe the income of the main member that will differ.
Okay. Dr. Mlobi, perhaps let's get your opinion here. Oftentimes people say, medical aids are very expensive. Why is that?
Well, there's no doubt about the fact that there has been pressure on, household budget in terms of the affordability of medical schemes. The cost of healthcare has been increasing and above inflation for as long as you can remember. And I think this is what has resulted in the contribution that members pay to medical aids escalating faster than maybe other commodities. And that has resulted, as we always say, that, when you look at household budgets, the medical scheme contribution tends to be now the third highest item in terms of cost to families. And I think that whole thing of they are unaffordable is based on the pressure that has been put on members. But we do try on an annual basis as medical schemes to try and keep the contribution income as low as possible. In fact, one advantage is the role of the regulator. The regulator also always puts a range within which they would allow a medical scheme to increase the annual contribution by on an annual basis. There's a circular on an annual basis that gives that guideline. And that perhaps contributes towards at least minimizing the annual contribution. But the pressure is there.
Okay. I'm going to come back to you about the role of the regulator in this, but let's just cross to our Cape Town studio and speak to Dr. Nyati and just kind of find out what the role of the administrator is. Oftentimes, people don't know the difference between the medical scheme itself and the medical administrator. You, of course, represent the medical administrator. What is the role of the administrator in all of this?
Well, a medical scheme has to collect contributions and they have to pay claims. They normally outsource that work to an administrator to collect those contributions on their behalf and pay the claims to the suppliers of private care. The other role of an administrator is managed care. Those are the people who decide on the funding rules, what is the right thing to pay, and form networks, etc. So to try and limit the amount of expenditure that schemes can incur to make it more affordable and sustainable over time.
Okay. All right. Let's get back to you, Dr. Conradi. Now, in terms of regulations now, I mentioned earlier the confusion around medical schemes versus insurance products, and I believe that there's new changes, the demarcation regulations coming. Just take us through what that is.
The demarcation regulations will be implemented from the 1st of April. And in the regulations, provision is made for, currently there is an overlap of insurance products, insurance companies selling actually the products that have to be sold by a medical scheme, like for example your primary care benefits. And because of the change of the definition of a medical scheme, those products will no longer be valid anymore, which means that the insurance companies will not be allowed to sell the primary care benefits that they currently sell to policyholders, unless they are registered as a proper medical scheme. However, just to give them enough time to, and not to leave a whole gap in the market, they may continue selling those products until for the next 2 years, until a proper low-cost benefit option can be in place to make sure that we don't lose and widen the gap.
Yeah.
And then leave certain members with a low income without cover. Now, based on exemption, insurance companies can apply to the Council for Medical Schemes to be allowed to sell these products for the next 2 years. As I said, until the low-cost benefit option framework will be in place.
Yeah, but there's talk of capping these insurance benefits because of this confusion. Is it outlawing them completely? Are they going to be completely outlawed, or are we talking about capping this payout on these hospital cashback plans?
It's capping on the hospital cash payout plans because of in the past there was unfortunately abuse of those products, and so there is a cap that will be implemented with the demarcation regulations.
Okay, it seems that we're gonna, this is going to be quite an informative show, but let's just take a quick break. After the break, we now discuss how medical aid benefits or medical scheme benefits work. Please stay with us.
Embracing our members in good health since 1968.
Africa becomes the new business frontier, bursting with opportunity and hope. With its rich natural resources and continental diversity, 11 million managers require development of executive management and business skills to unlock Africa's potential. Mancosa graduates have been driving business, entrepreneurship and innovation in Africa and the world. Mancosa. Dream it. We'll take you there.
It's so good, nothing else can replace just your slightest embrace. And if you only would be my own for the rest of my days, I will whisper this phrase, my darling, c'est bon.
If we are talking health, then let's talk seriously.
So what would perhaps be changed to say that evaluating of people that are sickly, those that are not, premiums should at least be compromised for people like us, because then I was paying 1.8, which I've never used before in my life.
The only thing that I would like to be improved with the scheme is the limit. I think they mustn't maybe have a limit. If you are covered, you must be covered in whatever way. The limit must be unlimited.
If they can make them a bit more affordable, especially for people who work, let's say, part-time. But let's say they come up with the lower rates, but then on a sort of longer-term basis.
It's overcharging and overcharging by practitioners. And another thing I can prefer is that if they can employ highly skilled staff, not relying on generalized computers, because at some stages when you're having problems, you can send them an email, but you'll receive the same reply, which is computer generalized.
If government can try to maybe open a section whereby they can have or AMA rules by changes so that it can also benefit the poor.
cut off that excess fee because umuntu angashona because of that 500 rand. I'm not too sure especially but then they wanted that 500 rand before I can even go to the theater. You know, then I had to swipe it. If maybe they can negotiate nama pharmacy, you know, how to come up with a solution on that. That will help also. So those two things.
Very interesting views there, from affordability to unlimited benefits to, you know, co-payments and so on. But let's perhaps get another view from Yusuf in Benoni. Yusuf, welcome to Health Talk.
Good morning. I would like to ask a panel, my daughter's connected with GEMS, and she got authorization for the procedure at Donald Gordon Hospital. But now they are refusing to pay the amount, even after getting the authorization. So what do I do in this case?
All right. Thank you for a question. Of course, we can't deal with specific, you know, individual challenges, but perhaps if there's anything there that you'd like to address, you're more than welcome to do it, Dr. Mulabi.
Well, from what Yusuf says, it sounds like he had an authorization, and the expectation is that when you have an authorization to use a hospital, the whole account would be paid.
Yeah.
What often happens is that the authorization, yes, for the admission has been given, but sometimes then a procedure or something is done inside when a patient is in hospital, that in terms of the rules of that specific scheme, right, the scheme does not pay. It's not a benefit entitlement. So there would be a shortfall on what a medical aid would pay. They would still pay the authorization, but then there is a shortfall, and this is what often causes this type of a problem. I'm not saying this is specifically the case, but generally this is what happens.
All right. Dr. Kondoli, I'm going to come back to you around, you know, the benefits, because there's one comment that refers to why should there be limitations when I pay my premiums every month. But before that, let's take Mohaunyana from Kwakwa. Mohaunyana, welcome to Health Talk.
Hello, sir.
Your quick question, please.
Yeah, you see, now I cancelled the GEMS, only the total 4,000 with liquid. So, because government introduced the NHI, they need to sound more about one bus and bus facility, money, free medical schemes in the country. So, like a child, they are 4,000. It prepared to NHI fund scheme.
All right.
The medical aid because in 20 white monopoly capital taking attended and the aging of the government. I was to be your OB in that to go or face of OPE we replace the cat.
All right. Thank you very much. Thank you very much, Mohaunyana. So in a nutshell, what Mohaunyana is saying is that, look, he cancelled his medical aid because he was paying premiums of 4,000 rands, and he feels that instead of him paying 4,000 rand, that 4,000 rands needs to go towards the NHI fund. You know, it'll make more sense, you know, that this one is channeled to the NHI funds so that everybody can have access to healthcare. But yeah, you can comment on the issue of limits. Perhaps let's just explain how these benefits are allocated, because there's a lot of, you hear about day-to-day benefits, hospital benefits, allied healthcare benefits, and so on. Can you just simplify for us, you know, how these benefits are allocated?
All right. First of all medical schemes must offer prescribed minimum benefits. And I will explain later exactly what those prescribed minimum benefits entail. However, on top of those that are prescribed and that must be offered by medical schemes, the scheme, according to its rules and according to the profile of the members and the claims, the ratio in the past, they then put together a set of benefits that they can offer on top of the prescribed minimum benefits. And
so perhaps let's talk about this PMBs, prescribed minimum benefits. What are these? And because there's been a source of huge problems for both the medical schemes, the administrators, the providers, everybody.
Yes. The PMBs involve serious illnesses and sometimes life-threatening illnesses. And they include, for example, an emergency condition as defined in the regulations of the Medical Schemes Act, and also 270 what we say diagnostic treatment pairs. And then also 26 chronic diseases as listed in the chronic disease list. Now, these conditions the 270 conditions must be funded by the scheme in terms of the diagnosis, the treatment, and the care of those benefits. And medical schemes have to fund those without co-payment or deductibles from a risk pool.
Yeah. So we hear that there's changes, contemplated changes. What is the rationale behind that?
Remember that prescribed minimum benefits, according to the Act, must be reviewed every second year. The last revision was done in 2010. And the Minister and the Department of Health then, they want more preventative and primary care benefits also to be included in the package. So the Council for Medical Schemes then decided it's time, because of also technological developments and new biological technology that are taking place currently, that we need to revise the whole package.
Yeah.
So this PMB review that we currently embarked on is a project to review the total package.
All right.
And to include some primary care benefits as well as preventative.
Yeah. I need to cross to Cape Town and give Dr. Lungi a chance to comment on one or two of the issues. But before that, let's take Anonymous. Anonymous, welcome. Anonymous, are you there? No? Yeah, Anonymous is gone. Dr. Nyati, let's get over to you. Would you perhaps like to comment on some of the issues? For instance, one comment was around simplifying processes and not having to, talk to computers and employ people that are skilled enough to attend to queries. Your comment on that?
Sure. Can I please get back to that last? I just want to make two comments. The first one was on how benefits are determined. So each medical scheme is different. They have a different medical scheme population. So in determining what benefits are best for that medical scheme, actuaries tend to look at the demographics of that scheme, the disease profile of that scheme, how those lives on that scheme claim, and then try to work out what the benefits should be for that scheme, up or down, depending on what it is the needs of that scheme are. Each scheme is different, and that's why in general the benefits are different for each scheme. And one of the key elements is that the scheme has to find a way to become affordable. The second comment I want to make is about PMBs. The intention of PMBs was to ensure that beneficiaries do not suffer lack of care for catastrophic events. Most of the current PMBs are hospital-centric. They cover hospital care. And I guess some of the changes now are looking at finding ways to make sure that those PMBs cover more than just hospital-centric service. We know that we need to focus, as El-Sabi said, more on prevention than the hospital care, which is late. On your question about processes, I do agree that in general, medical aids need to be much simpler. I do think we need to simplify the benefits, and I also do think that we need to simplify the way that one can access care and that care is paid for. To do that, so many things need to change. Some of them are regulatory, some of them are the way providers actually provide care. Some of the problems that we have is that a lot of providers work in single units, and so one can't coordinate all the care well, and it just provides a fragmentation in the way services are paid and provided for in the end.
All right. Okay. I mean, there clearly is quite a lot of stuff that we need to talk about. And we also have another comment, somebody saying, I'm a member of this medical aid. I pay 6,000 rands plus per month. But in 2016, April, I was informed that my medical aid is exhausted without using it even for flu medication, but mainly for consultations. At that point, I was already paying for myself, claims and prescribed medication, but I kept paying the medical aid 6,000 rands for the whole year to the medical aid, also paying for my claims and prescriptions on the other hand. Please advise. I guess this is what, we're going to have to talk about that in our next segment, in terms of why is it that some people run out of funds, and I think these are day-to-day funds, right, somewhere early in the year. And of course, I do know that we still have Tessa on the line, but Tessa, Please hold on. We're going to take your call immediately after the break. When we come back, we discuss these questions and the medical savings account. Please stay with us.
MedShield Medical Scheme doesn't just cover you when you're ill, we'll help you stay well. MedShield Medical Scheme, we don't just talk health, we do health.
Keeping you up to date with business developments.
There's no shortage of money in the system. There's a shortage of implementation capacity to actually get things done.
Always on point with news of the day.
May has promised radical social and economic reforms, fueling speculation over the future of current senior figures.
On the ball every time with all sports codes.
The Joburg side already have a quarter-final at home, and a victory against the Argentines will ensure home semi-final.
Accurate weather updates after every bulletin. Stay tuned to News Today at 3 p.m. from Monday to Friday on SABC News.
Welcome back. If you just joined us, we're talking medical aid, and with me in my Johannesburg studio is Dr. Elsabi Conradi, who's the General Manager of Stakeholder Relations at the Council for Medical Schemes. And next we have Dr. Stan Mulwabi, Principal Officer for MedShield, and in our Cape Town studio, Dr. Lunginyati, who's the Executive Director at MedScheme. We do have Tessa on the line. Tessa, welcome.
Good day.
Your question, please.
Okay, my main problem is I'm a breast cancer patient.
Right.
I belong to the Classic Saver with Discovery, and the nearest hospital, network hospital, to me is Morningside.
Yeah.
So just a little issue that I had going there to the emergency rooms, and the doctor on call saw to me, but the medical aid will not pay whatever happened that morning out of my cancer benefit. So from September to date, I'm just battling to have like over 5,000 Rand paid. And being unemployed at the moment due to the cancer, it's just a bit difficult. Thank you.
Thank you very much. I guess a third one.
Yes.
Do you want to take it on? Who would like to offer some explanation?
I will take it, yes. I just want to urge the members to make sure that they understand the rules of the scheme and the benefits, know what benefits are offered. And although cancer treatment is also a PMB condition and that the medical scheme must fund it, however, there are also to protect the schemes from financial risk, there are also rules that they may implement in terms of treatment, in terms of hospitals to be used, etc. And to look at Tessa's specific condition, I would urge her to contact the Council for Medical Schemes so that we can properly investigate and then see, where the problem is and advise correctly what should be paid and what benefits she is allowed.
Okay. Dr. Murabi, I mean, there's reference to the issue that, oftentimes benefits and benefit structures aren't properly explained or aren't adequately explained to the members. But we'll come back to the issue of, how to simplify the explanation. But let's just come back to this issue of funds running out, because this affects a whole lot of people, and people get so emotive about this whole thing. Please let's just take us through what savings accounts are, day-to-day benefits versus overall benefits.
Okay. I think let me start in answering the question. what is the business of a medical scheme? So the medical scheme receives contribution from members. And by virtue of those contributions that members make, they are entitled to a certain set of benefits. And I think this is the critical thing. There is a certain defined set of benefits that a member buys by contributing on a monthly basis to a medical scheme. And that those benefit entitlements are set out in the rules of a medical scheme. So what then happens is that members will be advised, usually by their brokers, what is the best option that they should actually buy. And this would be informed by the two things mainly. It would be what a member can afford and also the state of health of a member. And you have to try and get the best possible fit in terms of the option that you buy. So if you are a member of a medical scheme who uses primary health care a lot, you would want to buy a benefit option which has got a lot of benefits at the primary health care level. And that usually then is maybe should take care of your needs. If you are a young person who doesn't really, who is not ill, you won't be using your GP that often, but you want to cover yourself for catastrophic events, and that's usually hospital cover. So your bias would be you buy little on the primary healthcare side, but you cater for the possible catastrophic events like being involved in a motor vehicle accident. So you want your hospital cover to be okay. What then can happen is that sometimes that mix, you don't get it right when you buy an option. A person who needs a lot of primary health care caters very little for primary health care. You then go and use the little that you have bought, and then by March, you have exhausted your primary health care benefits. And it's simply because the option that you had gone for is not appropriate for your health care needs. And then the misunderstanding comes, I have a medical aid, I contribute on a monthly basis, but the doctor says I don't have funds. So the most important thing that we need to do is the advice that we get from our brokers. And most medical aids, in fact, in terms of the Act allows that a member of a medical scheme can have a broker, and the broker is basically your financial advisor who advises what is the appropriate option that you should take.
And we hadn't, described the role of brokers in all of this, but let's just take Lusanda on the line from Tata. Lusanda, welcome. Your quick question or comment, please.
Hello, Doc. My question is, I went to the hospital last year to remove my wisdom teeth, and I got the authorization before I went there. But now, after I came from the hospital, I received a letter that the anesthetic was not taken care of. Then I called my medical aid. They said that the hospital was supposed to submit a claim within 2 weeks after the hospital stay. Then when I tell them that, they continue to come after me. The bill now is risen to 10,000 from 6,000 for the anesthetic. I would like to know maybe what can I do to, because it seems like it was the hospital's failure to do the claim at the correct time.
All right. Okay. Maybe let's give Dr. Conradi a bit of a break and get to Cape Town, and because this is the administrator now. Dr. Nyati, I hope you heard the question. Claims not being paid. Yep. Your response?
So I guess there are a number of issues. When you get an authorization, you're informing us that you intend to go to hospital, and you intend to go to hospital for XY reason. That way, we can make sure that while you're in hospital, the care that you receive, we're checking that it's optimal, etc. Now, the problem comes in that providers of care, so doctors, anesthetists, pathologists, they also charge for care that they give you while you're in hospital. For that, they may do any number of things, which often medical schemes see after the event of the hospitalization and not always during the hospitalization. And at that, they claim different prices. So some of the problems that arise with hospital care is often not the actual hospital bill, often relates to the provider claims. And those range from not submitted on time, not linked to what you said you are going to be in hospital for, so it doesn't always correlate that you said you're going to be in hospital for this and now the doctor is providing for that, or the provider is charging a whole lot more than a medical scheme actually pays. Those are often the kinds of cases we see. So when we receive a claim such as this and it's escalated, we normally go through the process of doing the full investigation on behalf of members. We look at what it is that the case was. Sometimes we even contact doctors and hospitals to try clear it up. Often those queries are very well resolved because we now have more clinical information to understand what is going on.
Right.
You can imagine that all we ever really see are claims with numbers and codes, and if those don't correlate nicely with what we were told at the beginning, there's often a lot of investigative work that has to go into it to deal with it appropriately.
All right. Great stuff. Thank you. We'll come back to you, Dr. Jati, but for now, we just need to go for a quick commercial break, and after the break, when I give you hopefully some tips on how best to make use of your medical aid to preserve those benefits. Please stay with us.
Shield, embracing our members in good health since 1968. If we're talking health, then let's talk seriously.
The Kalahari Transportier Park is a large wildlife preserve and conservation area in southern Africa. Kalahari means place of thirst. The total area is 38,000 square kilometers. Approximately 3/4 of the park lie in Botswana and 1/4 in South Africa. South Africa embraced the concept of transportiers linking ecological reserves across national borders. On the 12th of May 2000, President Festus Mogae of Botswana and Thabo Mbeki of South Africa formally launched South Africa's first peace park. It has 200 species of birds, including vultures, mammalians such as black Kalahari lions, and large herds of herbivores, namely elands, springboks, blue wildebeest, and more.
Welcome back. We're talking medical aid, and my special guest from my Cape Town studio, Dr. Lungi Nyati, Executive Director of MedScheme, and in our Joburg studio, Dr. Elsabi Conradi, GM, Stakeholder Relations, Council for Medical Schemes, and Dr. Stan Mulwabi, Principal Officer for MedScheme. Now, we have Sheila on the line from Pretoria. Sheila, welcome to Health Talk, and your quick question, please.
Yes, good morning, everybody. Can I speak Tswana? Hello.
Can you try? We have viewers, not only within the borders of South Africa, but even beyond.
Oh.
So maybe English is a lot better.
Okay. I'll try to speak English.
Yeah, as quick as you can, yeah?
All right, my medical scheme is James. And then the thing that started the trouble, I changed my medical scheme and my bank card from savings to check, and then things started being wrong. Immediately after that, I had to travel to Pretoria to the medical aid. My medical scheme never received any. Everything was up and down. Everything I had to pay my medical scheme at the bank, and then thereafter I was operated upon doing a knee replacement, and then my medical scheme, my contributions were suspended. There was a time when they said I'm funded. I was supposed to be funded 5,000. I think it was in March last year. So it was never done, only to find that my medical scheme is not working on well. I don't know what happened. Immediately after the operation, then after that, I did it in October. Between the second week of October, I had to pay extra money for the contribution that was supposed to be taken the end of the month. So in October, I paid 1,335 rand for the operation. Not for the operation, for the contribution.
Yeah.
And then only to find that before the end of the month, I received a SMS saying that I must pay the same amount.
All right, Sheila, thank you. I mean, I can understand, and so sorry if, you seem to have gone through quite a lot of trouble. We'll try and get a response from our guests. But before that, let's just go through a few tweets that have just come in. GEMS have increased premiums of 15%, whereas salary increase in government do not reach double figure. This is Klupegam Dileni. And Mafofu says, my dad says I'm too expensive now, so he ain't putting me back on his medical aid, and those meds are expensive. Nikki says, better day-to-day benefits and lab tests be deducted from different benefits than day-to-day benefits. And Utapelo says, as much as I complain that my medical aid is so expensive, but it can save a life. Very true, isn't that so? Susan says, most citizens of South Africa can't afford medical aid, and the cost is just too inflated and exorbitant. They must really reduce the price. All right, it appears that obviously there's a lot of people with all sorts of problems, complaints, and perhaps through either lack of understanding of, or uncooperative providers, or that perhaps skip, the benefits aren't clearly understood. Your quick comment on what members' rights are.
Members must remember that the funds of a medical scheme, it's a trust fund. And those funds, or the money in the medical scheme, belongs to the members. So they are responsible, ultimately, also to make sure that the medical scheme administers the funds effectively. And therefore, it's important for them to also realize that from their side, they also have responsibilities in making sure that they understand the rules, they understand the benefits, and that they apply to if the medical scheme have a designated service provider, for example, rather use that service provider than go to someone that's not on the network and which service provider can charge any price, whatever they like. So that is one way that members can actually also make sure that they save on their day-to-day benefits. Then also there are responsibilities from the medical scheme. The medical scheme has to make sure that they communicate properly with the members in a language and via channels which are accessible to the members, so that they know and understand exactly what the medical scheme is prepared to pay for a particular treatment. The service providers also have responsibilities. They have to make sure that they upfront inform the member what the treatment options are, whether there are designated service providers on a particular medical scheme, and what the cost of the various treatments are, so that the member is fully informed and can make a proper choice, which is to the best interest of the member.
Well, let's hear from the scheme. Yeah?
Well, if you listen to the calls and the tweets, it is clear that some members have got specific problems that they are raising, that they have experienced. So I think what I would love to say is that when members have, like with us at Medshield, they would have a problem with us, they would raise a problem with us, and we would try to resolve it. I want to believe it's the same with all the other schemes that the members are complaining. But in the case where you really do not get helped, that's when the Council for Medical Schemes should be approached, because the Council is there to protect the members. So those members who have problems that are not being resolved by the schemes, I would advise that they please consult with the complaints division at the Council for Medical Schemes. And then the other two questions are about the annual increases being too high. I think we have addressed that earlier on. There is pressure. We try in our benefit design to try and make it as affordable as possible, but the pressure is coming from issues like new technology coming in, the cost of healthcare rises at above inflation. But as medical schemes, when we do benefit design and cost adjustments on an annual basis, we do try our best to keep those costs as low as possible.
All right. Okay. Let's take. I wasn't really planning on taking any more calls, but Dr. Mudisha from Kokstad. Dr. Mudisha, welcome to Health Talk.
Yeah, my question is, why does James prevent members from migrating to other medical aids which are even better against the Competition Commission's rules?
Okay. Thank you very much for a question. Quick one. Perhaps let's get response from CMS.
The members belonging to GEMS, they are normally state employed, government employees, and according to the Department of Public Services, they made provision and allowed GEMS to be the actual scheme for the for members belonging to or employed by government. So unfortunately, according to the employer contract and rules. That's right. Yes, that is something that was implemented in by the Department of Public Services.
Yeah. Okay. Let's get a comment from Dr. Nyati. Dr. Nyati, I mean, also remembering that we're trying to say how best can we advise people to use their medical aids responsibly. Your comments, please.
My comments. I'll have three main ones. The first one is probably one of the most important ones. Keep healthy. Most people are not as healthy as they could be, not looking after their health, especially those with chronic conditions. We know that the majority of chronic conditions are lifestyle diseases. So the healthier we are, the less we'll claim and the lower our contributions can be over time. The second one is we know that the healthcare world can be complicated. I think that members must choose a general practitioner, hopefully choose one general practitioner, and allow that general practitioner to be the one that coordinates the care and tells you need to go to this specialist, you need to see this physiotherapist or whoever, because by doing that, they can streamline the care and avoid you going to a pediatrician yourself, then deciding to go to an orthopedic surgeon, all of which can, in the end, cost you so much money when it could have been streamlined by a general practitioner. It's better to use one and not use more. The last one that I'll say is ask your doctor a lot of questions. If you can engage with your doctor and negotiate with your doctor around your care, speak to them about, are you using the medication that's in the scheme's formulary? How much are you going to charge? Are you on the network of my scheme? Ask those questions, and if you don't know, ask your scheme around the doctor that you see, because that helps you shave off all the extra bits of money that people end up spending because they're not following some of the best choices that have been made for them by the medical scheme or their administrator on their behalf to try and make sure that their benefits go as far as possible.
Very valuable. Dr. Mulawa, I'm going to give you the last 20 seconds.
Well, one of the most the things that we think are driving costs high is fraud. It is estimated that anything between 5 to 15% of medical aid contributes are being lost to fraud. So my appeal in terms of making sure that members can have their medical aids working for them is that members must not participate in fraudulent activities where you find that there are schemes that are where they go and use their cards for non-healthcare costs. I think if we could also have the help of members and healthcare providers in reducing fraud, we will definitely have medical aids being even the costs not escalating at the rate that they are escalating.
Very true indeed. Well, Dr. Stan Mulawi, Principal Officer, MedShield, thank you for your time. Thank you very much. Dr. Elsa Conradi, General Manager, Stakeholder Relations Council for Medical Schemes. Thank you for your time as well.
Thank you very much.
And of course, in our Cape Town studio, Dr. Lunginyati, Executive Director, MedScheme. Thank you so much for your time and contribution. All right.
Thank you very much for having me.
That's all the time we had, unfortunately, and that's how we're going to end our show today. Remember that you can join us again next week, same time. And please keep sharing those comments and views with us on via Facebook page and via Twitter. And remember that you can watch repeats of today's, at least this morning's show at 2 o'clock this afternoon and again on Thursday morning at 5 o'clock. I'm Dr. Salome Teng. Thank you so much for all your calls, your tweets, and please do stay healthy and take care of those medical schemes. Bye-bye.